Hello, this is Dr. Irvin Sahni with Spine Center of Texas. I would like to talk to you a little bit about knee arthritis, hip arthritis, and joint replacement. Many people are plagued by knee arthritis and hip arthritis, and in our practice, we try very hard to avoid joint replacement. Joint replacement is an open procedure requiring inpatient care, either general or other types of anesthesia, so that the patient can basically have their knee or their hip opened up and have the arthritic component of their knee or hip removed and replaced by either metal or plastic or ceramic, as there are many different types of joint replacements. Many patients come in and they tell me they've been either told by their doctor or told by a radiology report that they have arthritis, and they're very concerned and feel that they need to have a joint replacement. I don't believe this to be true. I don't operate on x-rays, I operate on people. And in many cases, someone can have terrible arthritis, but if they don't have a lot of pain and they have good function, then doing a joint replacement really may not be the best answer for that patient. Oftentimes, you can lose weight, change your diet, change your activities, try anti-inflammatory medications, do physical therapy, and of course, an exercise regimen, and you can reduce the pain from a hip or a knee despite having x-rays that show even moderate and in some cases severe or advanced arthritis. However, when all of these things have failed and a patient who is relatively functional wants to go back to that optimal function, then a joint replacement certainly can be a very effective treatment. Really what we're doing is sort of capping your bones. If you think about having a crown put on a bad tooth, that's kind of how you can think about a joint replacement. Although the incision is large because we have to resurface or take out the bad portion of the joint, and the incision does seem to be a bit large, really all we're doing is typically shaving off the very ends of the bones, somewhere between 2 and maybe 10 millimeters, depending on the severity of your arthritis in, say, the case of a knee, or the severity of your arthritis in, say, the case of a hip. So depending on your particular situation, in some cases, the amount of bone that has to be removed can be a great deal more aggressive. I would say the majority of patients really only have to have 4 or 5 millimeters of the ends of their femur or their thigh bone and their tibia or their shin bone, and in some cases the undersurface of their patella, just a few millimeters removed, and then place metal caps, in the case of patella, a plastic cap, so that you don't have that bone-on-bone arthritis. Some people have severe angular deformities. In other words, they're bow-legged or they're knock-kneed. That's called a varus or valgus deformity. A varus or valgus deformity can really affect function and strength as it puts your muscles at a mechanical disadvantage. This can be a reason to do a knee replacement much sooner than a person who just simply has pain from arthritis. Because if you can get that pain to improve with non-surgical or conservative treatments and you can get your function back without surgery, that's optimal. That doesn't usually turn out to be the case for people with a severe angular deformity. Additionally, a person who has an unstable knee, maybe from an old ACL tear that they never had repaired, or some other ligamentous injury, or for some other reason they're unstable, that again is likely to be solved with a joint replacement, especially if it's painful or you're having instability of the knee, making it difficult to walk or function. Those are cases where it's probably wise to go ahead and proceed more quickly with a joint replacement. But again, arthritis and an x-ray are not really a reason to go straight to joint replacement. And in fact, people who have a stable knee that does not have an angular deformity, and even if they have moderate arthritis, can be treated with a conservative treatment called a G-block or genicular nerve block, followed by what's called a radiofrequency ablation. And again, as long as the knee is stable and the issue is really just pain, we can, in many cases, burn the nerves that cause pain in the knee and make it possible to go without a knee replacement, maybe just for a few more months or a few more years, or possibly indefinitely. So in conclusion, knee replacement may be an answer for someone with severe pain and severe arthritis, but certainly other things should be considered. The patient's function, level of disability, and severity of arthritis should all be taken into consideration. And in my opinion, all conservative treatments, including G-block and RFA, which is relatively new, should be at least thought about, if not attempted, before proceeding with an open knee or hip replacement.